Hello, everyone, and welcome to the next NESTS series webinars. I hope you're all doing well today. I'm Kenneth Brown, the training manager at Stroud Medical. With me on the panel are my two colleagues. I think you know them very well, Lorenzo De Nova and Sergio Rudeloso from Italy, from Northern Italy. Hello, guys. How are you? You're doing well? Good.
Very good. Thank you very much.
I'm also very, very proud and honored to have on the panel our two experts today, Professor Cristina from Rio in Brazil. Hello, how are you?
Hello, good morning.
Nice to see you again.
Nice to see you again.
And Dr. Carlos from Sao Paulo. Good morning,
Hello.
Dr. Carlos.
Good morning,
Nice.
everybody.
Very good. So without further ado, we just have the normal technical presentation here to remind you all about the GoToWebinar setup here, what we see on the screen. If you need to change the language, if it's not your local language that you are seeing, it's this button, this globe button on the top of the panel, which is most probably on the right of your screen at the moment. You can also enlarge the webcams if you're viewing from a computer or a laptop by clicking these arrows, these diagonal arrows here. And you can write your questions into the questions here or into the chat. And we encourage you to do that, please. Ask our panel a lot of questions. That's why we have them here just for you all. And we also have a couple of files here to download under handouts. We have those there. And yeah, there we go. If you are viewing by mobile telephone, you can swipe the screen to change from the presentation to each of our presenters. Okay, so please, if you're using the mobile phone, you can do that. We often get questions about people dialing in by telephone. So without further ado, I would like to pass you on to Professor Cristina, who is going to tell us a little bit more about dialysis access fistula and her experience.
Thank you very much for the invitation. Can you see my presentation?
Yes, we can.
It's a pleasure to be here. I'm going to share a little of my experience with mechanical debulking devices for excess salvage. Okay, we have always to consider when treating occluded native or prosthetic AV dialysis fistula, the site of occlusion. You have to imagine which is the most probable lesion. So for distal native fistulas, you have the ones close to the arterial anastomosis. You have also on the outflow tract, the ones in between the puncture sites. For basilic brachial fistulas, we can also have the ones at the transition from the basilic to the axillary vein. We have also the cephalic arch lesions. And for prosthetic grafts, we have the venous anastomosis site. Considering failing fistulas and occluded fistulas, the subject of this lecture is about the occluded ones. We should always try to treat them before they occlude, because when they occlude, we have also to do the debulking process, the thrombolysis or thrombectomy. When thinking about the time of occlusion, considering all the literature on peripheral venous interventions, we have deadlines of 10 days, 14 days, and 21 days at last for recommendation of time of treatment. Of course, the earlier the time of treatment, the better results we can get. We consider when treating occluded grafts or native fistulas 21 days as the deadline, and we can use either the pulse spray therapy and the mechanical thrombectomy technique. The goal of the occluded access treatment is thrombus, debulking, and coated lesion treatment. The contraindication for declotting for treating these occluded accesses is time, delta time, over 3 weeks, early non-functioning fistula, because it's always due to primary failure. So this should be done through surgical revision, and patients with high risk of embolic events, which are poor cardiopulmonary reserves patients, right to left shunts, and mega fistula with high thrombus burden. Considering two techniques, the advantages and disadvantages, the main advantage of mechanical debulking is that there is no need for fibrinolytic drugs and all the complications and the risk related to that type of drug. So it carries a lower bleeding risk, it's a fast and a day clinic procedure with early hospital discharge, and the only drawback of the mechanical debulking is the higher cost of the device. In literature, when considering patency, since early patency till 4-year patency, 12-month patency, you have a wide range of efficacy because they consider different types of devices. There are two main papers on Aspirex and Rotarex for mechanical debulking of fistulas. And this is the Aspirex, it's a single center retrospective study with 13 native fistulas and 14 prosthetic fistulas. It showed 100% channel of thrombus removed, and it was associated with high pressure balloon for culprit lesion treatment, with an 81% clinical success, primary patency in 1 month of 53%, and 4 years of 33%, with no major complication. The Rotarex paper is a single center prospective study. All of them were done in graft fistulas, in graft AV fistulas. There were 30 procedures in 22 patients with a 94% of technical success and a year primary patency of 75%. The failure predictive factors were female gender with smaller vessels, diabetes, and occlusion time, longer occlusion time period. So this is a review in literature in which the failure predictive factors were similar to the one before: female gender, diabetes, longer occlusion time, left-sided access, older age, and usage of immunosuppressive drugs. Considering the technique for fistula salvage, we have the remote arterial and the proximal arterial. We can either come from arterial femoral or brachial radial artery. This is an example of an occluded brachial axillary graft fistula, where you had a total occlusion of the arterial anastomosis. So if you either come from the radial or from the brachial or from the femoral artery, you can get access to the whole fistula. We like the retrograde venous puncture, so we use the access as far as possible from the arterial anastomosis in a retrograde fashion. So this is used for proximal lesions. The antegrade venous puncture is exactly the opposite from the before. So we treat outflow lesions far from the arterial anastomosis, and you use an antegrade puncture site as close as possible to the arterial anastomosis. So this is an example of superficialized basilic vein fistula, where you have a puncture as close as possible to the arterial anastomosis, and you get access to almost all the venous outflow. The apex technique, it's not not used so much in Brazil because we usually don't use this type of looped graft. So you puncture exactly the apex of the loop, and you can, with a single access, get to the arterial site or the outflow venous site of the access. We prefer for the occluded fistulas or grafts the double puncture technique. So first, you get the retrograde venous. You puncture as far as possible to the arterial axis to get access to the proximal site, and you get an antegrade venous puncture as close as possible to the arterial anastomosis to get access to the outflow of the fistula. Always avoid this type of double crossed puncture because you're going to miss this area of the clotting. So this is to be avoided. Always puncture as far as possible from each other. So the first thing you gotta think about the access site is where is the possible lesion site to choose the simplest access site and the lowest morbidity site. Considering the thrombectomy technique, we have two mechanical effects of the device, the fragmentation of thrombus and aspiration. The devices used are Aspirex or Rotarex, either the 6 French or 8 French device. So you consider the access sheath, the device profile. If you use a 6 French, you're going to use a 6 French sheath. If you use an 8 French, you're going to use an 8 French sheath. I always prefer the larger one for maximum declotting. The endoluminal crossing guide wire is on the surgeon's preference, but we have to remind that the device goes over an 018 guide wire that usually comes with it. And I usually go through the venous outflow first. So I go for a close antegrade venous puncture first, do the outflow declotting, and then I go to a retrograde puncture in the direction of the AV anastomosis. First, the antegrade, then the retrograde to treat the arterial anastomosis. Always short movements from proximal to distal. Attention to the collecting bag. If what's coming out of the device is clot, is only blood or nothing at all. Attention to the heating of the system. If it's too hot, take it out. Allow system irrigation because it may be caught, it may be obstructed by clot. Attention to friction signs. So if there is a different sound or a different touch feeling, you need to reposition it or take it out and allow system irrigation also. Full epironization throughout the whole procedure, and after declotting, culprit lesion treatment. So the way to do it, if I go too fast, I'm gonna miss the surrounding clot. So I have to go slowly with short forward and backward movements. So the slower I go, the better effect I can get in the surrounding clot. So I'm going to give you two examples. This first one is a declotting and treatment of an AV graft, brachial arterial anastomosis, the proximal one, and distal axillary vein anastomosis. So I begin with an antegrade puncture in the direction, antegrade direction of the outflow. You may see the device is a 6 French Rotarex system over an 018 guide wire through the outflow track. So this is the control after the first passage, after second passage, with some backflow into the arterial inflow. And then we can see the culprit lesion, that's at the venous anastomosis. And then it was treated with a balloon angioplasty with a good result. So the outflow is taken care. Then we go to the retrograde puncture as far as possible from the arterial, and we can see at the first angiography the clotted proximal area. Then we proceed with the rothorax passage over an 18 guide wire. We go as close as possible to the arterial anastomosis, but not through the arterial anastomosis. We reserve a Fogarty catheter, a 4 French or 5 French Fogarty catheter to take out, to pull out the arterial clot, the platelet-rich arterial clot at the arterial anastomosis. And then the final control, there is some lack of contrast feeling due to the first puncture. And this is an example of a native brachiocephalic AV fistula in which it was used an Esperex 8 French debulking technique. In this technique, we used a double puncture, but we began with a retrograde puncture because when we did a duplex scan, we saw that we found that the distal outflow vein, cephalic vein, was free of thrombus, and only the proximal part was out of thrombus. So we decided it was a node, a large fistula. We decided to use the larger device, an 8 French sheath was positioned in a retrograde way as far as possible from the arterial anastomosis. We can see a 5 French headhunter catheter through the anastomosis and the first angio, where we can see the distal brachial artery and the proximal larger brachial artery to the anastomosis, which is occluded. When we treat native fistulas, we try to predilate the strict fibrotic venous stenosis to avoid device entrapment. So this is the control after predilation. This is the first incidence, and we dissociate both arterial and venous outflow, and we can see the clotted proximal area. This was done with a 5mm balloon, the predilation. So this is a road mapping that's used to guide our thrombectomy system, and this is the occluded area. This is the site of puncture, retrograde puncture. And this is the 8 French sheath. This is the device going through the clotted area. And this is the control. This is the Esperex 8 French. And this is the control after thrombectomy, successful declotting. And we can see the culprit lesion. It's a lesion close to the anastomosis. It was post-dilated with an 8mm balloon. And that's the final result after the proximal declotting and PTA. We may see then there is a missing clot in the distal outflow tract and a lesion, and this is the retrograde puncture site. We are not able to treat both lesions through this puncture, so we're going to have to go to a second puncture, to a double puncture in an antegrade way, as close as possible to the anastomosis. This is the 8 French sheath, and we are able to treat those lesions to go through thrombectomy of this clotted area, small clot, and then the final result of the whole outflow tract until the cephalic arch, and with a good result. And conclusion, the lessons learned with the cases, we can always save the occluded native fistulas and grafts as long as we have a good timing. So the shorter the time, the better the result. We usually use Esperex for native fistulas and Rothorex for grafts. The size, the larger, the better. If I can use the 8 French device, I go for the 8 French. The access, it depends on the probable lesion and the amount of thrombus and the extent of the thrombus. I always consider direct venous outflow puncture because it carries lower morbidity and easy hemostasis, always heparinization, through systemic heparinization in culprit lesion treatment. Thank you.
Thank you very much.
Thank you very much, Professor Cristina. That was wonderful as always.
Thank you.
Well, we have a very quiet audience today. What's going on today? Normally we have some questions by now, but I think I think we have some questions coming from the panel.
Yeah, no, also we have some questions from our audience, which is a little bit shy, but is warming up now. So now the questions are coming. And we have a question about flow. We always say that flow is important with our devices, both Rotarex and Aspirex. So the question is how you manage to have flow in this kind of indications. If we can have maybe an answer from both of you.
Yes, in my experience, when I treat occluded AV native fistula grafts, I usually have a very short segment of occlusion, usually a 10 to 20 centimeter occlusion. And if, especially when I go with a double puncture, I usually don't need flushing because I'm working through a short sheath. If I go through remote access and I use a long sheath, I usually go with continuous saline irrigation. But if I work with a short sheath and I have an arterial flow through the graft, even occluded, I go with I choose not to irrigate.
Okay.
Very good. And you don't have any heating of the guide wire or anything like that, I guess. If you're quite familiar with these techniques, then that's not so much of an issue. Although I think you know, it's certainly something. It's a question that very often comes up with us: is how do we get an adequate flow to the catheter? And sometimes in these short sections, we just belt and braces, as we say in English. Sergio, did you have another question there on your side?
And first of all, if you don't mind, guys, I may want to launch a pause from for our audience, if you like, so that we understand from our audience if they already treated or not any dialysis access with our device, with Rotarex. So I'm asking you all if you already treated an occlusion in dialysis access with Straub Medical products. Then, in the meanwhile, while we are waiting for the result of this poll, first of all, I would like to ask to Dr. Carlos Andre if he has another opinion, or if he wants to ask something about the infusion. We know that you know, to have always flow at the catheter head is so important to avoid the heating of the system. I don't know if he normally uses this or not. We know that you know, we always also have to pay attention to distal embolization. We don't want to infuse too much fluid to avoid also maybe some embolization at the hand level that we know it's very hard to manage. What do you think, Dr. Carlos?
I think the embolization is a reality, but I had never problem with that. I think with almost all procedures that you do, you have some embolization. And the things that I'm concerned is not treated to the stenosis before the thrombus aspiration. So do the thrombus aspiration as well as you can, and after that you do the stenosis, so the embolization is not going to be too large.
Can I make a comment on that?
Sure.
The main technique you may use to avoid embolization is not to go with the device through the arterial anastomosis. So yes, we always use the Fogarty catheter that easily passes through the sheath that you are using for the final breakthrough of the platelet-rich thrombus at the arterial anastomosis. So that's why we do that technique, to avoid distal embolization. We've never had distal embolization with that technique. And that's why the heating of the systems is a question, a very important issue. And the care to how the device works is another issue, because you can avoid traumatic lesions. You can avoid the device being caught at the venous wall, especially at the stenotic areas. So you have to be very careful to the heating of the system, the signs of malfunctioning of the device. So you are very close to the lesion when you treat grafts and AV fistulas.
Yeah, and also, Dr. Cristina, in your presentation, I really like so much the sentence, go big or go home. We know
Yes.
that when you're treating big thrombus load, we want to use, as you said, a bigger catheter, like an 8 French, because, you know, distal embolization is also up to how much thrombus load we leave into the vessel. So we know if we use big catheters, we have a lot of aspiration capacity, and distal embolization, it's really reduced. Together with a good technique, we would suggest people to always keep the motor running to avoid stopping the motor many times. And you know, I fully agree with your technique about Fogarty. We also have other users that are going through the anastomosis with our device, but in a really careful way, so very slowly at the level of the distal anastomosis. And you know, always be sure that at least the part of the thrombus before the anastomosis has been totally removed by the catheter. So yeah, I fully agree with the technique and with the use of big catheters to avoid distal embolizations. So we are, yeah. Please.
Another tip, I was reading one paper last night to get some new info, and there was one case relate about the malfunction of the device with the guide wire being stuck at the device. And something we have to be careful about is exactly transitional areas and bending areas, because this type of device, that's a mechanical machine that works through fragmentation, you need a straight area to work. That's why for grafts, it works very well. Grafts are faded not to fail. For native fistulas, where you have curves and you have a pseudoaneurysms, etc., you have to be more careful. Those are the harder and the most difficult to treat. So you have to be more careful to that, because of the areas,
you said in the presentation, for me, it's very important. I don't know if people realize that pay attention to the sound. Every time, pay attention to the sound, because Rotarex and Desprex, they say to you if you have some problem. The sounds change in the same time. You have sound change, you stop it, and it starts again, and you have no problem.
Yeah. Sounds, also flow. We always recommend to check the flow in the collecting bag, which is actually what is preventing the catheter heating up and you know, also coagulation inside the catheter. I see that now we have plenty of questions here in the section, but if you agree, guys, I would go with the second presentation from Dr. Carlos Andre, and then we can open all together the Q&A session at the end. Is that okay? Okay, please.
Can you see my screen?
The screen, yes. Please share the presentation, which is not on the screen now yet.
Okay, I will. Are you guys seeing?
Yes.
Yeah.
I'm not seeing you, but I will start. Do you see my presentation here?
Yes.
Okay. Christina makes my work harder, but I will try. Good morning, everybody. My name is Carlos Andre. I'm a vascular and endovascular surgeon. I'm talking from São Paulo, Brazil. The aim of today's presentation is talking about technical aspects of the endovascular salvage of hemodialysis access using Rotarex or Aspirex. A practical guide. The materials that you need, that we will need are a radial 6-French introducer. As you realize, it's a little bit different from Cristina, but I think the better way is the way that works. And the radial 6-French introducer, the 21 gauge needle, a non-hydrophilic and hydrophilic guide wire, a vertebral 4-French catheter. I really like the Cords brand because this, at the same time it's a spin on the bottom, it's a spin on in the tip. A bare metal or a covered stent, if is it possible for you, a semi-compliant balloon, a inflator, and a Rotarex or Aspirex device. The Terumo TR band is a compressor that I always use at the end of the procedure. In the next slide you will see. The procedure steps, as long as you follow the procedures, this technical success probably will come. The radial artery cannulation, initial angiography, ultrasound guided fluid selectivation. All I talk in the next slides, guide wire exchange, heparinization. You do the things the same way, the results are going to be better. Control angiography, stent deployment, stenosis angioplasty, a final angiography, and introducer removal. You see you can see in this picture on the left, the radial introducer. The transradial introducer I really like. In the next video, you see the transpassing the guide wire and how easy to do, and the complication is really rare. In the picture on the right, the 21 gauge needle. This is a micropuncture introducer set from Cook, but it's not always needed if sometimes the radial introducers had the 21 gauge needle as well. This image is the ultrasound guided artery cannulation. I don't know if you realize, but this artery has less than 2 millimeters. The deeper is 2 centimeters in this image. So I prefer punction with the transversal way because it's better to see the tip of the needle. As long as the needle is inside the artery, I push a little bit more to stuck the needle in the skin and don't the guide wire losing. At this image, you see I transpassing the guide wire by the needle, and afterward I'm transpassing the 6-French introducer. I really like the radial approach because with this approach you have some advantages, like you can see the artery and the vein, both the artery and the vein at the same time, or the graft. And this is a very ergonomic position to operate as well. This video, the same time I put the introducer in the skin, I push the guide wire a little bit more to give me support and have no problem with the introducer set. This image is very interesting because you just see the artery. This is like a graft, axillary, brachial axillary graft. You just see the artery. That's the important. How to say this is how to I say is important, the ultrasound guided, because you don't see the occluded place and the anastomosis with just the angiography. With this image, you can see the catheter, the guide wire, and the brachial artery by the ultrasound. At the same moment I put the catheter in the anastomosis, I push the guide wire, spin the catheter in the occlusion, and push the guide wire again, so the guide wire, as you can see, is inside the graft. The image, you can see everything with the ultrasound. You even can do all the procedure with the ultrasound and it is better for our radiation. Almost every stenosis in grafts is located in the anastomosis, the distal anastomosis between the vein and the graft. Crossing the stenosis is not hard. You just push the catheter near the stenosis, pull and push the guide wire, and you transpass easily, as you can see in this video as well. At this picture in the left, I'm transpassing the rotorax by the guide wire, and in the right, you can see the rotorax. With the energy cable and the rotorax, they fit to each other magnetically. It's very easy to get together in the operation room. In the video in the right, as Christina said for us, you have to be patient. I always push 2 centimeters and I pull 1 centimeter of the catheter, and this procedure has to take longer, at least 5 minutes to 10 minutes for thrombus aspiration. In the video on the right, you see the thrombus that goes to the collecting bag. This is from a patient with a 31 days long occlusion. And as you can see, the rotorax can debulk and you can take the thrombus off very, very easy. It's impressive how you can make it with such a long time occlusion. This is a picture of the initial angiography. Some filling defects, it's common to find. Don't worry about. In this specific case, I transpassed the rotorax again, and afterward I did the angioplasty, stent deployment, and the final angiography. At this video, you can see the most important radiological signal that show you this procedure is okay or not. The most important is the velocity of the contrast. If you have a very fast contrast passing through the graft, the procedure is easy in the end. Sometimes you can see some filling defects, but if it's too small and the velocity of the contrast is okay, the procedure is in the end. This is a picture after the introducer removal. This is named the TR band from Terumo. It's very easy to use. It's safe. The patient don't complain from pain, and you avoid pseudoaneurysms, bleeding, or hematoma. In my 30 cases, I had never problem with the access. I made a revision in literature, and there is a meta-analysis from the American Cardiology with 31,000 patients using the transradial approach, and complications are really rare. Occlusion don't pass 5%. In my cases, with 30 cases, I just had one case that I didn't have technical success because I made an hematoma. And it's very close to the literature that you had to have a technical success over than 90%. Of course, when you treat graft, it's easier than when you treat native fistulas. So it's more for grafts than for native fistulas. Sometimes natives show us as a very challenging procedure. As Sergio said, for me, I had some more time, so I will extend a little bit more with another case. That was a very challenging case with a patient that I did 1 year later, 1 year ago. At the initial angiography, you can see even in the left and the right, you don't see the vena cava, you don't see the subclavian, the brachiocephalic vein anywhere. So that patient had no more access, even femoral vein, cava vein, vena cava, nothing. I had to do something. When you see a case, a very challenging case like that, you sometimes have to make some different approach. I did it by the fistula and by the femoral vein as well, and I did the angiography at the same time. Afterward, I can transpass the guide wire. Transpass the guide wire, the procedure sometimes takes too long, but you realize that is going to be okay, and you're going to make it possible. On the left, you see the first angioplasty and the first control. It's not okay, but as long as you go and with the port of and to get it it's a good procedure, and make the vein for hemodialysis. And after, I put a stent in between the graft and the vein. I put another stent in the brachiocephalic vein, and I had a good result at the end. This was a challenging case. The patient had this graft for 1 year, and I had to take the graft off because of infection. And the last month, I had to make another procedure. Now she has a hero graft, but was not by occlusion. It was for infection at first. Thank you. I hope you enjoy.
Dr. Carlos, thank you very much indeed. That was wonderful. Very nice indeed. Nice presentation from both of you. Thank you very much. And we have a lot of questions that have come in from our audience today.
Yes.
They were a little bit slower to start, I think, this morning, but now they have all woken up and we have a lot of questions coming in. So that's wonderful. So thank you very much. Sergio, shall I hand over to you for asking some of these questions?
Thank you, Ken. So first of all, I think a very nice point brought up from Dr. Carlos Andres. Actually, I think is the most confusing part when deciding if we should approach an occlusion dialysis access with Rotarex or with Aspirex. So we know that normally, if we're talking about grafts or stents, we will always go for Rotarex because it's safe. We have not residual valves inside the vessel, and we can go easily with Rotarex. When we are in fistulas, we always struggle to decide which one should go, Rotarex or Aspirex. So provided that, you know, as a company, we normally stay a little bit conservative if the doctor doesn't have so much experience in treating dialysis access with our device, and then we would suggest to use Aspirex, but we know that the results also, as per data presented by the Professor Cristina, are better with Rotarex, probably because of the bigger thrombus load we are removing. So question is, what's your deciding, I would say, algorithm to understand if going with Rotarex or Aspirex? And then another interesting question from the audience is, after 1 or 2 weeks of a navi fistula occluded, shall we try as well, or is too late to use mechanical thrombectomy?
when the occlusion is less than 5 days, I almost every time I use the Aspirex because the thrombo debulk is not needed. And the Aspirex has one advantage because the head doesn't spin, and if you can transpass the catheter with no concern of lesion. But the Rotarex, most cases I use Rotarex because there are a lot of grafts and native fistulas. Sometimes the thrombus is very stuck in the vein. But the line for me is 5 days for using one or using another one. It's an experience. It's from my experience, not from other people do. But as the result is going well, that's the way I do.
Yeah, thank you. And Professor Cristina, would you like to add something?
I agree with you both. Definitely for grafts, I use Rotarex. It's more effective. And for grafts, we know it's safe to use Rotarex. So I go for the larger one and for the most efficient one for the Rotarex. When we are dealing with fistulas, native fistulas, I usually try to do it the earlier as possible, and I use for early ones Aspirex. And if I have an early occlusion, I use the larger one. If I have a later occlusion, harder thrombus, I can try to use a 6 French Rotarex that's smaller, so I try to compensate. But I always try to use this 8 French Aspirex for native fistula.
As I use almost always radial approach, even for distal fistulas, I use the radial approach, and more distal the radial. I always use the 6 French device. I realize is it possible with the 6 French device make a good aspiration, because there is a trick, or that I would say is you can press the skin sometimes and make the debulking easier with that way, and not using a device with a high profile.
Yes.
In Rio, we don't have much graft. Most of the fistulas are definitely native fistulas. I see very few AV grafts. So, and most of the patients with ocular fistulas are female. For instance, the 2 cases you showed were female, I saw. And
it's too much difficult to do.
Yes, and
native fistula female, it's too much difficult than graft, of course.
Yes, and as we do a lot of native fistulas, we usually do the radiocephalic ones. So most of the patients have occluded radial arteries. That's why we don't use that elegant access. I think it's very elegant, and it's easy to transpose the lesion because you are in the direction of flow. So and you can access the whole fistula. But the problem is that most of these patients with failing accesses, they don't have the free radial artery. So we come to that problem. The good point about the radial artery is that the hemostasis is very easy. It's different from the brachial, that you have a risk of bleeding and compression of the nerve. So the only problem is that most of the cases, I don't have that option.
There's an interesting point in São Paulo. People that has health insurance don't have distal veins. It's impressive because I think they go to the hospital all the time, and they lose their veins in the hospital at the ER. It's impressive. So most of my fistula is or a vein or graft are proximal, and that's I didn't like to do that, but that's the thing that I have in most of cases.
Shall we run while we are maybe answering another other question? Shall we run a second poll for our audience? Because at the end of the day, I think that you know the access site is one of the key points when approaching a lesion. So let me run this poll, which is just a second.
We can see it now, Sergio.
Yeah, but it disappeared for me. So can you please read the question? Yeah,
so
thank you.
Which is your favorite access site? And so we have venous proximal, arterial distal, double puncture, other, or retrograde femoral vein. These are the options.
Exactly. And actually, we have another question. Thank you, Lorenzo, from the audience. When peripheral venous access? I mean, when this option would be your favorite, Dr. Carlos and Professor Cristina?
I don't understand peripheral venous access, but I'm going to try to answer. I usually use the outflow vein for access. That's my favorite. Other than that, I can use, as venous access concern, I can use the femoral vein. When I use the femoral vein, the two drawbacks that I have to use a long sheath for support. And if I use an 8-branch system, I'm going to have a little difficulty finding that sheath, that long sheath. And the other problem about the femoral access is that you work retrograde. So if you have a complete occlusion, sometimes it's a little more difficult to go through it. But it's a good access.
And would you go in that case for the double puncture?
Yes, I usually for occluded AV fistulas or grafts, I go for the double puncture, venous puncture.
Okay.
And maybe Sergio, no,
yes.
sorry. No, sorry.
For grafts, I always use the arterial, the radial approach. But for native fistulas with aneurysms, I like the double puncture as well, because removing the introducer is very easy. Just pass a suture across the introducer, and you can do a stitch across the introducer and remove with no compression.
Okay, great. In the meanwhile, we are seeing the results of the poll, and 41 says double puncture, 30% proximal vein. We also have a small percentage which are using the arterial distal puncture. Okay, perfect. And then, sorry guys, but since we have one question in Portuguese, allow me to translate this and to ask this to Professor Cristina. How are you doing the hemostasis when you puncture the fistula? The suture on the skin with X suture, or?
Yes, I use an X around, as Carlos said, I use an X around the sheath, and that's all. And the patient can use the fistula right away.
Great. Okay, perfect. Guys, from the panel, do you have further questions? I'm trying to follow up the question we already answered. I don't know if you guys want to add or ask something. Otherwise, we have some more.
Yeah, maybe there was a question. Oh no, if you want to go on, Ken, go on.
No, I think it was Dr. Carlos who was going to.
Okay.
Sorry, you're on this side of me.
just one thing, talking about the femoral vein or even the artery for treating. Sometimes you don't have devices with just such a which is such a large and wide enough to reach the lesion. And I did this in this way in some cases, but in some cases you'll get in problem because of how large is the device.
And we have another question here from the audience about your technique, Dr. Carlos Andres. I think if I understood correctly, you will go through the anastomosis. You will treat first the arterial anastomosis from the radial artery, and then you proceed with a thrombectomy to clean the venous outflow, correct? You don't go in a retrograde from the vein to the arterial plug. You will treat first the arterial plug, correct?
Correct. I do everything from the radial artery, and I find the anastomosis by ultrasound.
Okay, and you.
I don't do it the retrograde way, just in the graft or nothing there.
And every time I think you perform the Barber test for the radial access, correct?
Correct.
Okay.
Every patient. I had 30 patients treated, but 25 of them with radial approach, because 5 of them the test was not good.
Okay.
Okay.
Guys,
there is a question about the double puncture. So when you puncture first retrograde and then antegrade, if you remove the first introducer sheath, or if you leave it there and you can work through it. So
I usually remove before puncturing the other one, because I wanna declot it all, and I don't wanna get anything stuck, any clots around the previous sheath. So I take it out and I go on with the procedure.
Okay.
Okay. And one other question about your technique of using Fogarty on the arterial plug. How do you remove the clot then? Will you just move it back and then take it out with Aspirex, or will you try to take it out from the introducer, or you do a surgical access?
We don't have any way to do it without a surgical access. As I do it all percutaneously, I just move it out, try to do some more thrombectomy, and there is no problem. It's too small to cause any problem.
Okay. Okay.
I think there is a question about DCB use after aspiration. So we also have, I don't know if you want to run another poll, Sergio, or we can just listen to the answer, both from Professor Cristina and Dr. Carlos.
I would say in the meanwhile, we launch also the poll. If you use a DCB in treating dialysis access or not, and what is your opinion, Professor Cristina and Dr. Carlos?
I'm not used to use DCB. I like using stents. In DCB, I think I used two times. It is not enough to tell you if it's a good result or not, because just two cases. The things that I have read, it's not reach the results that we need to make the procedures in all patients.
I never use stents in the outflow track. I indicate stents for example, the venous anastomosis when the PTA alone is not enough, when I have elastic recoil, or central venous lesions. For peripheral outflow lesions, I never use stents. So what is left for me is the non-compliant balloon to go over the fibrotic aspect of the lesion. And whenever possible, if I have a drug-coated balloon available, I impregnate with paclitaxel to avoid early restenosis.
Okay, okay. Thank you very much for sharing this. We have another interesting question which goes back to distal embolization to artery. You know, again, because of this fluid infusion that we normally recommend to always have flow inside the catheter. You know, just a technical suggestion, we know that with a 6 French, either Rotarex or Aspirex, we are aspirating 45 ml per minute. With 8 French, Rotarex and Aspirex, we are aspirating 75 ml per minute. So normally we would recommend to provide normally 50 to 70% of this amount through our infusion. You know, we need to remember we cannot infuse too much, otherwise the catheter will not be able to aspirate all the infusion we are putting in the patient, and then we will have more risk of distal embolization. So very careful infusion would be my suggestion. I don't know if you want to add something.
As I said before, I usually don't use infusion for AV fistulas or grafts because it's too short. So.
Yeah, you know, we normally the first thing that we will tell you how the device is working is the fluid and in the collecting bag. So if from the access you are using, you still have fluid in the collecting bag, that's enough. We remember that fluid is permitting us the transportation of the thrombus outside the body, so it's very important. But if you have fluid from you know, the proximal vein or the artery, for sure you don't need infusion. And again, if you then clean the device frequently, you can also work with no infusion in fistulas. Is something we see often. Let me share the result for the question because I think is interesting. 51% of the audience is not using DCB in dialysis access. 28% is using. 21 is not sure. Probably we are still waiting for the evidence of the benefit of this device, correct? Okay, I don't know, guys, if you agree, since we are more or less almost late, if I may ask to our expert a couple of key learning points they want to highlight of this session for our doctors which are starting, or I also see experienced doctor making questions in the chat. If they want to give them just a couple of take-home messages before we close the session.
My message for all guys that's it is going to make that procedure, don't give up, because the access needs you, and you have to trust that it's going to be okay. It works. That is the most important than technique. You don't have to give up. And the second thing is using the ultrasound. Use the ultrasound. Ultrasound is, I think it's there. I escaped from some troubles because ultrasound guide made your procedure easier, faster, and with less radiation.
Okay, Professor Cristina.
I agree with Carlos. Adding to the ultrasound need, the interventional surgeon should understand the anatomy of the fistula. So it's very important to understand what was done. So if you're not a vascular surgeon, if you're not used, call the surgeon and ask what he has done. So it's easier to intervene when you know where you're going and what you're going to do and what you're going to face. So first you have to understand the fistula. I think that's the hardest part when working with access. So the second, you have to follow the step by step, pay attention to the device, listen to the device, and use all the available devices you have to treat the lesion. So never give up. The life of the patient depends on the access. So
that's it.
Perfect. Ken,
very good.
Do you want to close the session? While
Not really. I really enjoyed the session. I don't really want to close it.
Okay, so let's start a new one from
Yeah,
scratch.
let's go again. Shall we go a second time? No. Thank you very much, Professor Christina, Dr. Carlos, for joining us today, sharing your knowledge with our audience here. We have some 120 people online, which I think is really quite a nice number, as I know there's a lot of these webinars going on just now. So nice that they choose us to spend their day with. And thank you to the whole audience for joining us today. I think you would agree this has been another very successful NESTS webinar. Lorenzo, Sergio, as always, pleasure to see you. Thank you very much. And now we'll close the session. We look forward to seeing you in a couple of weeks for the next NESTS series. Take care, everyone, and thank you very much. Have a lovely day.
thank you.
Thank you. Bye-bye.
Bye-bye.